All right, good morning, everyone. So we're going to have a little bit of a different start this morning. I'm going to introduce one of my co-chief residents, Katie Martin, who's one of the inpatient chiefs at the VA. So Katie Martin's going to present an award before the speaker.
Good morning. As Megan said, I'm Katie. I'm the inpatient chief at the VA currently, and it's my great pleasure this morning to present the recipient of the Beeson Award. So some of you may know we've been giving the Beeson Award to a distinguished clinical faculty member in the Department of Medicine for about a decade, and the award is given by the internal medicine residents to someone that we consider an incredible clinician, a great teacher, and someone who really demonstrates the qualities of humility and integrity in their clinical practice and teaching with residents. This is in honor of one of the physicians who used to work in our department, Dr. Paul Buse, who was one of our VA clinicians at the time that he worked with us and really exemplified a lot of those qualities. So we, after much discussion with the residents, sorted through our nominees, and our ultimate winner was Dr. Jeff Redinger. Come on up. Yeah. So I'm gonna make Jeff stand here for just a minute and listen to the nice things that people said about him. We could not be more pleased to have Jeff win. Personally, Jeff was the chief when I was an intern, and so I'm always like, "There's my chief." He really does exemplify these qualities in a great way with our students. Currently, as a clerkship director at the VA for the medicine students, and really active in teaching both for residents and for students. So some of the things people said, so his passion for teaching and creating the best learning environment for residents and medical students is evident in everything he does. Through his leadership, he shows there is more to be learned than just the science of medicine, and he's a shining example of the humanity, humility, and compassion that goes into the art of medicine. He has amazing rapport with everyone employed at the VA, basically, because he goes out of his way to know them and ask how they're doing. He's wonderful with patients, demonstrates what it means to be compassionate, kind provider to all who work with him, and has a very kind manner that residents and medical students find reassuring, and they know they can approach him with any concern. It will be taken seriously. One more. I had the great luck to work with Dr. Redinger on VA wards. I knew he was an astute clinician and skilled teacher from his presence at VA morning reports, but it was working on a team with him that introduced me to his humility, compassion, and integrity. Some examples of those qualities were that Dr. Redinger never dismissed a patient nor a team member's concern, but gave them his full attention until they felt reassured. Similarly, whenever we walked through the hospital on team rounds, he would enthusiastically greet numerous people by name, from custodians to nurses to interns and attendings. Seeing this collegiality, compassion, and humility practiced by a physician who is so highly regarded for his skill as a clinician and educator made a powerful impression. He also exceeded his reputation as a teacher. For example, taking us to the micro lab to review our patients' cultures and giving us chalk talks that were relevant and timely. For all of these reasons, I strongly support Dr. Redinger's nomination for this year's Beeson Award. We could not agree more or be more pleased, so we just want to thank you, Jeff. I know, yeah. This is this guy. So you'll get this, and we're going to, yeah, suitable for framing.
House staff, thank you so much. Thank you for helping me stay humble, and thank you for helping me approach my job with humility every day. I really appreciate it.
I'm going to hand things over to Dr. Page, who's going to introduce our speaker this morning.
Good morning. So this is actually very timely because this is the John Leonard Lecture, one of the two endowed lectureships in the Division of Endocrinology and Diabetes. And John Leonard was actually the very first recipient of the Paul Beeson Award. So that this comes in very well timed. So I did want to say a little bit about John Leonard. Whose friends and family and co-faculty endowed this lectureship after his premature death in, when was that? 1982. Thank you. Okay. I should just leave it to our speaker. Oh, that's because it says it there. Very good. Powers of observation. All right. So just a little bit about John Leonard. John Leonard was born in Minnesota to a small farming community in 1939. He was educated at the University of Minnesota and did his house staff training at Harbor UCLA, where he began his lauded career as an incredible teacher, as both intern of the year and resident of the year during his internship and residency. He came to Seattle in 1968 to do his endocrinology fellowship with Al Paulson at the U.S. Public Health Service Hospital, which the younger audience may know as the Amazon building, which is now again PAC Medical Center. This was an era when the Public Health Service Hospital really was a house of giants, including Marvin Turk, King Holmes, Seymour Klebanoff, and Donnell Thomas, who went on to receive the Nobel Prize in bone marrow transplantation. So it was really quite a time for medicine in Seattle. John Leonard was a superb clinician and clinical scholar, but was really most well known for his teaching. Following a very successful endocrinology fellowship, he spent a year at the University of Iowa as junior faculty before returning to Seattle, where he was initially a physician at Virginia Mason, which was then called the Mason Clinic, where he again won teaching awards. He returned as full-time faculty to the University of Washington as the chief of endocrinology at the Public Health Service Hospital, and then became the chief of the medical service there in 1977. He was invariably friendly and interested in what everybody had to do, and really was committed to superb patient care. In 1982, unfortunately, at the young age of 42, Dr. Leonard took a well-deserved vacation to Hawaii, where he died very unexpectedly of a myocardial infarction, leaving his wife and their 4 children, ages 12 and 17. This was very traumatic, actually, for the University of Washington, as he was really a beloved scholar and teacher. At the time of his death, we did not have very many teaching awards, and the Paul Beeson Award was created later, and he was actually, as I noted, the first recipient of the award, and this was posthumously. So that's just a little bit about John Leonard. And as I said, this endowed lectureship was really a culmination of efforts from his friends and family, so we're very grateful to them. So I am very privileged to introduce our speaker today, the recipient of the John Leonard Lectureship, Dr. John Buse, who is an MD PhD here visiting us from the University of North Carolina. He's the Vern S. Cavanis Distinguished Professor, the Chief of the Division of Endocrinology, the Director of the Diabetes Center, the Director of the CTSA, as well as the Executive Associate Dean for Clinical Research. And that all goes on his header, all those different titles. So he's a very important part of the University of North Carolina medical community. He did his undergraduate training at Dartmouth, and then his MD PhD, a PhD in immunology at Duke University, before doing residency and fellowship at the University of Chicago. He started at UNC in 1994 as an associate professor with tenure and has been there ever since. John has numerous awards and has really been a leader in the field of both type 1 and type 2 diabetes care, and determining and developing new drugs and proving the safety and efficacy of those. In particular, he's been at the forefront of developing GLP-1 agonists, which have really transformed the way we treat type 2 diabetes. And he's chaired seminal studies in diabetes care, including being co-chair of the ACCORD study looking at cardiovascular endpoints in patients, particularly with diabetes. He has also been the president of the Medicine and Service Committee for the American Diabetes Association and the chair of the National Diabetes Education Program in 2014. He has over 300 publications, and in June he will receive the American Diabetes Association Outstanding Achievement in Clinical Diabetes Research Award, which is actually an incredibly prestigious award, and that will be happening, as I said, in June. So we're very fortunate to have Dr. Buse here, and look forward to his talk on type 2 diabetes, new guidelines and controversies. Thank you.
Thank you. It's a pleasure to visit Seattle again, and it's been wonderful to spend time with Dr. Page and some of the others from the endocrine division. It sounds like wonderful things are happening here, and it's always been a hotbed of endocrinology. Because we had these awards and long introductions, I may cut out part of what I say, but I did need to make some disclosures. We do a lot of work with the pharmaceutical industry, particularly in the design and conduct of clinical trials. To date, these have not provided me direct financial benefits, but a lot of benefit nevertheless. So at the end of the presentation, you should be able to reprise the American Diabetes Association guidance with regards to the management of hyperglycemia in patients with type 2 diabetes. I do want to try and touch on A1C targets, but that might be the part that I cut out to make sure there's time for questions and answers. And then a big part of the talk is really to try and understand how to incorporate all the studies that have been published since the fall of 2018, when the last set of American Diabetes Association guidelines occur. Things are happening so fast in this diabetes clinical therapeutics area that we could have a guidance statement that came out online on October 5th with a very rapid publication cycle, and still there have probably been 4 relatively seminal studies since then. The bottom line is that managing type 2 diabetes has grown increasingly complex. And so the effort of this ADA-EASD group was to try and simplify this as much as possible, particularly for primary care providers and the large segment of the American medical community that's engaged in caring for patients with diabetes now. So the publication on the right is this ADA EASD guidance that I had the privilege to lead the US part of the delegation. It's now being updated in a month-by-month basis in an online version of the Standards of Medical Care in Diabetes, which I would refer to you as sort of the Bible of diabetes care. And then I will try and mention this guidance from the American College of Physicians with regards to glycemic targets near the end. So I think the most important piece of that ADA EASD guidance is really the focus on empathic patient-centered care. It's essential that we recognize that the people who are actually taking care of diabetes here are really patients, and that we as physicians or diabetes educators, dietitians, physical therapists, et cetera, for the most part are at best coaches. I think we spend too much time trying to tell people what to do instead of really engaging in effective coaching. And so we really need to try and understand patients better, where they live, their values, what's important to them. And the important piece of that is that it's important that we help them understand at least part of what we know so that we can really engage in meaningful discourse in determining best opportunities. So the central part of this document is really putting the patient at the center of care. We've known this for a long time. A lot of this work on patient-centered care actually was developed here at the University of Washington, but nevertheless, it's an important piece of this document. And the central focus of the way the discussion should go is really around shared decision-making, making sure that patients have access to diabetes self-management education and support. That's the long version of access to diabetes educator, and in healthcare systems and insurance schemes and in society, recognition that there does need to be more support for patients with diabetes to deal with their chronic illness. There needs to be a continuous reassessment of how patients respond to therapy with a focus on adherence and persistence, not so much the judgmental focus on adherence that this is a bad patient because he doesn't do what I say, but really trying to provide the necessary support and coaching to improve adherence. And most importantly, I think from the perspective of providers, is to avoid clinical inertia. I could spend a whole talk on that. It is truly, mind-boggling how long it takes to, on average, for patients to go from a hemoglobin A1C of 7 on drug X to more drug of the same drug or a new drug. And even if you look at patients with an A1C over 8, and even if you look at an A1C over 9, in patients on more than one oral agents, the most recent data is it probably takes 2 years before intervention actually occurs. So, we as individuals can really do a lot to try and avoid that clinical inertia. So again, with the patient, the center of care, the recommendation is that the sort of wheel of care is presented here. So the recommendation is that we really need to, in the initial evaluation and at least on an annual basis, try and assess key patient characteristics. And as I'll get to in a moment, probably the most key patient characteristics in the therapy of type 2 diabetes is whether or not a patient already has cardiovascular disease or chronic kidney disease. And then think about specific aspects of the individual that could impact the choice of treatment. So that's the process of deciding what the individualized hemoglobin A1C target is, understanding how important weight and hypoglycemia may be to the patient or the patient situation. Then using shared decision making to create a management plan, agreeing on the management plan with specific, measurable, achievable, realistic, and time-limited goals, implementing the plan generally with visits approximately every 3 months, ongoing monitoring support, and then finally review and revision of the plan depending on how patients respond and the changing dynamics of their health. So with that as background, I'm going to talk briefly about lifestyle and metabolic surgery and spend most of my time talking about medications. But that's not because lifestyle isn't important. And I think the point that I want to make about lifestyle is we increasingly understand, and we've been preaching the importance of lifestyle for decades, but we increasingly understand how big the impact of lifestyle therapy could be. So the GLP-1 receptor agonist, the cash price is $30 a day, so around $10,000 a year. If we provided $10,000 a year worth of lifestyle support for patients with diabetes, would be the best drug that was ever developed, and I hope to convince you of that. So lifestyle is divided into several aspects. Medical nutrition therapy probably is the most important bit in type 2 diabetes, and it's defined as education and support to help patients adopt healthy eating patterns. There are really two aspects to it. One is diet quality and the other calorie restriction, and those two really can be divided and have completely different impacts. So diet quality has to do with, what kind of diet. Is this going to be a low-carb diet or a low-fat diet or a Mediterranean diet? The bottom line is there's not a lot of strong data to suggest that any particular ratio of proteins, carbs, or fats is right in general. Generally, there's one of those kinds of ratios that might work out optimally for a given patient, but often it's a bit of a challenge to try and figure out what that is. In general, we want to emphasize foods that have known benefits like fruits and vegetables, and de-emphasize foods that are more associated with harms like trans fats and other processed foods. There's pretty good data and extensive references in the main document that it's probably the Mediterranean diet that has the best track record, not only with regards to outcomes, not specifically in the diabetes population, but including the diabetes population, but even in regards to hemoglobin A1C reduction, which is the major focus of this paper. With regards to calorie restriction, it's absolutely clear that lowering hemoglobin A1C does come in proportion to weight loss. And a 9 kilogram loss of weight on average translates to a hemoglobin A1C of about 0.9%. I'm going to talk a bit about this direct trial that has been published over the last couple of years with really remarkable effects on diabetes remission, but also in reducing cardiovascular risk factors, the amount of glucose-lowering drugs that are used, and with regards to safety and quality of life. And a variety of these calorie restriction programs are available commercially and actually are quite effective. So with regards to this direct study, I think this is the most remarkable lifestyle study that's ever been done. It was done in general practice facilities in the United Kingdom. So these are literally modest-sized clinics in modest-sized towns with modest support in an excellent and well-organized healthcare system, something that we don't really have access to here in the United States. But it is theoretically doable. And they randomized these practices to control intervention, which was guideline-based diabetes care, and the intensive intervention, which was a structured weight management program, the details of which are copyrighted as Counterweight Plus, but freely available. Remarkably, in those intervention practices, when they went to patients that met the inclusion criteria, 28% of the patients who were approached agreed to participate in this trial. So this wasn't zealots that were willing to do anything to lose weight. These were the hoi polloi of diabetes care. The entry criteria were quite broad, 20 to 65, a BMI between 27 and 45, and they had to have diabetes duration of less than 6 years. They could not be on insulin therapy, and you'll see why that's important later. And what they did was they developed this counterweight program in collaboration with the practice nurses, which are much like the practice nurses that we have in our clinical programs, and when available in these practices, dietitians. They delivered the intervention, not physicians. They withdrew all of the patient's anti-diabetic medications and their antihypertensive medications at the start of this, quote, total diet replacement, which was about 600 calories a day of powdered meals. And that went on for about 3 months, is based on progress. Some people did it for less, some people did it for more. I think the outer bounds was 5 months. And then they had a 2-month period of gradual food reintroduction and a weight maintenance program, which really started from the very first visit, but did involve potentially going back onto this total diet replacement. The primary endpoint was at 12 months, but they continued to follow these patients out to 24 months. And patients were supposed to have monthly appointments. They averaged about 8 of these monthly appointments a year. So there were 2 co-primary endpoints. One was the remission of diabetes, which was defined as a hemoglobin A1C of less than 6.5% on no medications. And you can see that 46% of the patients achieved that endpoint in the intervention group at 12 months, and at 24 months, 36% persisted. If you look at weight loss, the second co-primary endpoint, the average weight loss was 10 kilograms at 12 months and 8 kilograms at 24 months, highly statistically different from the control intervention. And when you look at the percentage achieving remission, there's a pretty linear association with the amount of weight loss. So you can see that if they lost less than 5 kilograms, the percent with remission was quite low, less than 5%. In those that had more than 10 kilograms of weight loss at 24 months, 64% were in remission. So a pretty remarkable effect on not only glycemic control, these people all had an A1C of less than 6.5%, but also on the ability to do this without the use of medications. Further secondary outcomes all showed benefits: reductions in blood pressure, reduction in blood pressure medications, improvements in triglycerides, enhanced quality of life with a variety of instruments, and a reduction in serious adverse events at 12 and 24 months. So the consensus recommendation from the American Diabetes Association, based on an early look at this direct trial, was that an individual program of medical nutrition therapy should be offered to all patients, and that all overweight and obese patients should be advised about the health benefits of weight loss and encouraged to engage in a meaningful program, which could include food substitution. Physical activity is the second part of lifestyle intervention. In these giant meta-analyses of hundreds of somewhat well done, generally small and generally short studies, the A1C reduction is about 0.6%. More exercise is better, supervised exercise is better, and there are broad benefits from exercise therapy, and therefore there's a recommendation that patients with type 2 diabetes should be advised to increase physical activity. And then I'm not skipping medications. In the ordering, in the guidelines, we do put metabolic surgery last after discussing medications, including weight loss medications. But metabolic surgery from the American Diabetes Association is indicated in patients who have failed non-surgical therapy for obesity, in those people who have a BMI of greater than 40. So hopefully, if you have these kinds of patients in your practice, there's someone here who can help you with, or there are many people here who can help you with non-surgical therapy of obesity in those patients. If that is unsuccessful, they should consider metabolic surgery. And then more specifically, if people have poor glycemic control, so whatever A1C target you're trying to achieve, whether that's less than 8% or less than 7%, if they have poor diabetes control and they have a BMI over 35, should consider bariatric surgery. There's less definitive language around the people with a BMI of 30 to 35, where also for improved glycemic control, that could be considered. There are a number of contraindications and certainly complications that are important to engage in shared decision-making with the patient around. The benefits in metabolic surgery are similar to the direct trial with regards to high rates of diabetes remission. In patients that are not on insulin at baseline, it's about 70% of patients remit after gastric bypass surgery or gastric sleeve procedures. Clearly improved glycemic control, reductions in glucose-lowering medications, and the weight reduction that we expect. There are notable risks, including the need for reoperation in 5% or so of patients. The fatality rates in these surgeries now are very, very low. And there is a subset of patients that are poorly understood who really have insufficient weight loss and late metabolic complications. So again, lifestyle therapy and metabolic surgery are the two kinds of therapy that we have that can lead to diabetes remission. Now for the rest of the talk, I'm going to really focus on medications, and the good news and the bad news is we have lots of choices, and what we really aim to do in this guideline is to try and make navigating those choices easier. So there's a huge table, it's like 5 pages long in the journal, that goes through all the treatments of diabetes, including the lifestyle therapy that we've just discussed, but also the oral medications. So there's now, depending on how you count it, about 12 different classes of diabetes medications that are available, and in some classes, some difference among agents with regards to their efficacy or side effects. And this tries to really summarize that in a relatively approachable way. And then there's a section which is really about the strategies for implementation. So it's one thing to have all these tools, but it's another to sort of have a strategy for how you're actually going to deploy these tools in individual patients. So the first step in the algorithm is metformin with comprehensive lifestyle management. And the use of metformin is based on its long history literally 50 years globally since 1995 in the United States, with well-determined efficacy, safety, tolerability, and lots of clinical trial data. Though metformin has not been definitively shown to reduce cardiovascular risk or, frankly, risk of anything over time, there are large numbers of studies that are examining these in more detail, including studies aimed at cancer prevention and even reducing nursing home, sort of global global level of maintenance of the ability for self-care in the elderly population. There are a number of prominent people and certainly a large number of pharmaceutical companies that would like everyone to use combination therapy early in diabetes. And though there's a rationale for doing so, it's not been well demonstrated in clinical trials. So the recommendation of the group would be not to do this as a matter of routine. However, if you had a patient whose A1C was more than 1.5% away from their goal, for the most part, most single drug therapies wouldn't achieve that difference, and so the farther someone is from 1 to 1.5% from their A1C goal, the more you might feel inclined to try one of these combination therapies. But I got a great example to share with you about why I personally think it's a bad idea. And this comes from, hot off the presses, May 3rd, the FDA approved this combination of dapagliflozin, an SGLT2 inhibitor, saxagliptin, a DPP4 inhibitor, and extended-release metformin as a once-a-day adjunct to diet and exercise. So you have a patient, you say, Bubba, you're too fat, you're too lazy, go exercise and watch your diet, come back in 2 months, we'll see how you're doing. The A1C is 8.5. We're going to whip this triple combination therapy on you and fix your diabetes. So here is the only data in the package insert. And the thing that you might note here is that all these patients were on metformin at the time they were randomized. There was a 3-arm randomization to saxagliptin alone. The combination in red, saxagliptin alone on the background of metformin, dapagliflozin alone on the background of metformin, and then the triple drug therapy. And what you can see is the triple drug therapy, which actually started from a baseline treatment with metformin, is more effective than either of the others, but you're dealing with marginal returns of benefit. So the difference here in A1C reduction is much less than the difference from here to here. So there is a bit of a law of diminishing returns as you get to higher order therapies, and particularly for the people in the primary care community who might feel inclined to do this. If you look at the prescribing information, it's 47 pages long, and there's 19 items for patient counseling, ranging from lactic acidosis, an adverse effect of metformin therapy, to Fournier's gangrene, an adverse effect of SGLT2 inhibitors. So it is, I think, perhaps the most off-putting thing you could do for a patient who's transitioning from not very good diabetes care to a new drug is to lay on them 19 different things, life-threatening things they need to worry about. So after metformin, this is the general approach. So I'm going to go through this in much more detail, but it starts with establishing whether a patient has atherosclerotic cardiovascular disease or chronic kidney disease. And if they do, there's a compelling indication to do what's in purple and orange that I'll talk about in a moment. If they don't, the areas of focus is hypoglycemia, weight, and cost, and we'll talk about that later. So these are the GLP-1 receptor agonists that are available now at the top. So they are injected, at least as of today. They're not the same as insulin, very different compound. They work to stimulate insulin production from pancreatic beta cells. They reduce glucagon production. They have some effects on gastrointestinal motility, and they produce satiety in the brain and reduce food intake and weight. And there are differences among these agents with regards to their backbone. So exenatide and lixisenatide are derived from a Gila monster peptide. So it was a salivary protein of Gila monsters that happens to interact with the GLP-1 receptor, but isn't even the GLP-1 of the Gila monster. And then the others are all derived from the human GLP-1 structure with various switches and add-ons to extend the duration of action. The SGLT2 inhibitors are pills. They work by inhibiting a renal tubular transport molecule that results in glucose being in the urine. This glucose in the urine goes with some sodium in the urine, and so it lowers glucose, it lowers blood pressure, and it lowers weight. There are some things that are near at hand. So there's a every 6-month implanted osmotic pump, like some of the birth control preparations. So it's a titanium rod that goes under the skin that's under review by the FDA. And then there's an oral formulation of semaglutide, a currently marketed product that's under review by the FDA. And both of these could be available before the end of the year. Then dapagliflozin is an SGLT2 inhibitor that's under review with the FDA. And then there's all kinds of fixed dose combinations, but I've already trashed those for you. There are some situations where you might consider that. So, since the last set of recommendations from the American Diabetes Association, which was in 2015, as opposed to the prior recommendations, which were, you know, there are all these good drugs, you know, when you fail one, do another. Last time we winded it down a bit, and we had recommended pathways for people who were overweight, recommended pathways for people where hypoglycemia was a concern or cost was a concern. But what was new, really new in this guideline was what to do in patients with atherosclerotic cardiovascular disease. And that was that people should be treated with a SGLT2 inhibitor or a GLP-1 receptor agonist that has proven cardiovascular benefit. So the considerations in thinking about this data is that atherosclerotic cardiovascular disease is defined differently in these trials. All of them call established cardiovascular disease prior MI, prior stroke, or revascularization. Some of them also included patients who had symptoms and stress imaging procedures with documented areas of decreased perfusion, or angiographic evidence of, in some cases, a greater than 50% lesion, in some cases a greater than 70% lesion, in some cases 2 or more lesions greater than 50%. And then some studies allowed patients at very high cardiovascular risk. And this very high cardiovascular risk was in part that these people all had to have diabetes, and then they had to have 2 or more, generally additional risk factors, but it wasn't like hypertension was enough. It would be hypertension with evidence of left ventricular hypertrophy or proteinuria. So big time cardiovascular risk factors. And though what you'll see is recommendations that you might consider using this drug or that drug, in fact, all of the evidence is based on single experiments. And generally, we don't make strong treatment recommendations unless you have 2 or more trials with a particular agent. But I think overall, the gestalt, you can establish a sort of understanding of what these classes of drugs might be doing across these experiments. And there are differences in trials, and they're generally bigger in the GLP-1 class than in the SGLT2 class, but it's unclear whether the differences in results are related to differences in the drug or a difference in the design and conduct of the experiments. And we can talk about that later, but we'll just leave it at that for now. So the first step in patients who need additional glucose-lowering therapy after metformin and comprehensive lifestyle therapy is to assess the cardiovascular disease status. And if patients have cardiovascular disease, it's a compelling indication for certain therapies. We would ask people to try and divide these populations based on whether atherosclerotic cardiovascular disease predominates. Are they having more trouble with angina and MIs and stents, or are they having more problems with heart failure or the manifestations of chronic kidney disease? If atherosclerotic cardiovascular disease predominates, the suggestion is to use either a GLP-1 receptor agonist or an SGLT2 inhibitor, and if that's not enough, to do them both in combination. If heart failure or chronic kidney disease predominates, the recommendation is to start with an SGLT2 inhibitor. Unless it's not tolerated or contraindicated, then you could think about a GLP-1 receptor agonist. So in the clinical trials, the level of evidence for benefit arguably is stronger for liraglutide than semaglutide than exenatide in the once-weekly formulation. That's not to say that there's evidence that one is better than the other. It's just that the level of evidence, the conduct of the trial, the number of participants, the number of events is greatest for liraglutide. There will be additional data, I think it's on June 9th at the American Diabetes Association, about dulaglutide, a very popular agent in the class. This study includes more people who didn't have clinical cardiovascular disease at baseline than the other studies, so it'll be of great interest, and we don't know yet where that will go. With regards to the SGLT2 inhibitor, the strongest evidence to date, particularly because they have a mortality benefit, is with empagliflozin, but similar results with canagliflozin. And after the publication of this paper, dapagliflozin was also reported, but it's not for me to put it in the hierarchy, though if you ask me to, I can tell you later. In patients who have heart failure or chronic kidney disease, the rationale, the recommendation is to use an SGLT2 inhibitor preferentially. And the rationale for that is, first, we know that patients with type 2 diabetes are at increased risk for heart failure, both with reduced ejection fraction or HFrEF, as well as preserved ejection fraction or HFpEF. In the SGLT2 inhibitor trials, as I'll show you in a moment, there have been consistent reductions in hospitalization for heart failure, as well as other cardiovascular outcomes in patients treated with SGLT2 inhibitors versus placebo. But these trials weren't really designed as heart failure trials, and the majority, like more than 90% of the patients, did not have heart failure in these trials. So we don't have perfect evidence in this regard. And then other caveats, there is no evidence to date of cardiovascular benefit in patients who only have risk factors, that haven't had clinical events before. And frankly, the combination of GLP-1 receptor agonists and SGLT2 inhibitors has not been studied for cardiovascular outcomes. There's some hints from some very small subgroup analyses that there may be additive benefit, but that aspect of this recommendation is pretty much in an evidence-free zone, but it's there. And then lastly, there's recommendations that in patients who have type 2 diabetes and chronic kidney disease, so that would be so-called G2 or G3, so an estimated glomerular filtration rate between 30 and 90 and any level of albuminuria, that in those patients, whether or not they have cardiovascular disease, you should consider using an SGLT2 inhibitor. If not tolerated or contraindicated, you could use a GLP-1 receptor agonist. And I would just point out that there are differences in the labeling of the 4 SGLT2 inhibitors available in the United States about what level of GFR is required to start it, what level of GFR is required to stop it. And this is because the higher the GFR, the better the drug is as a glucose-lowering drug. It's not related to adverse effects. And in the cardiovascular outcome trials, patients were included down to a GFR of 30, and as I'll show you, there are benefits down to a GFR of 30. So to summarize, this main portion of the document recommends that the first step in making treatment decisions on the management of hyperglycemia in patients with type 2 diabetes who are not achieving glucose tolerant targets after metformin is to use an SGLT2 inhibitor or GLP-1 receptor agonist in those with atherosclerotic cardiovascular disease. If they have heart failure, preferentially use an SGLT2 inhibitor. If they have chronic kidney disease with or without atherosclerotic cardiovascular disease, consider using an SGLT2 inhibitors. And thus, these clinical features, atherosclerotic cardiovascular disease, chronic kidney disease, and heart failure, are really important markers of the need for treatment modification. So let me take you very quickly through some of the data. And this is largely from a series of meta-analyses that have been done by the same group. And I don't know how they get away with this using the same data set and doing multiple meta-analyses. But in any case, this is on the primary endpoint of these trials, which was MACE, major adverse cardiovascular events. So non-fatal MI, non-fatal stroke, and cardiovascular death. And here you see that the effect of GLP-1 receptor agonists and SGLT2 inhibitors in the setting of established cardiovascular disease is substantial and similar between the GLP-1 receptor agonists and SGLT2 inhibitors. If you look at patients with multiple risk factors, there is no evidence of any benefit of these agents with regards to reduction in MACE events. It works to lower glucose, they work to lower weight, but not cardiovascular events. If you look among the GLP-1 receptor agonist trials, there's substantial heterogeneity with regards to the effect on MACE endpoints. And so ELIXA and the EXCEL trials had either no effect or no statistical effect on MACE as an endpoint. And it's unclear whether it's the drug, it's the pharmacokinetics, or the trial conduct. But there is heterogeneity there. But not with regards to the risk factor only group. None of these agents have shown benefit in the risk factor only group. With regards to heart failure, there's not a substantial effect of GLP-1 receptor agonists on reducing the risk of heart failure. Among the SGLT2 inhibitors, there's consistent and substantial effects on heart failure, hospitalization, with the SGLT2 inhibitors. There's now been a sub-analysis, a deeper analysis of the DECLARE trial, one of the SGLT2 inhibitor trials, with regards to the heart failure population. So they divided patients into people who said they had heart failure, people who said they had heart failure and somewhere they had evidence that it was with reduced ejection fraction, or patients who did not have evidence of reduced ejection fraction but did have a history of heart failure. The important points are there was evidence of heterogeneity, statistical heterogeneity, with regards to cardiovascular death or hospitalization for heart failure. Basically, the patients with reduced ejection fraction seem to be the ones that have greatest benefit on this primary endpoint of this study, hospitalization for heart failure and cardiovascular death. If you look at the hospitalization for heart failure alone, there's at least a hint that there seems to be broad benefit across the SGLT2 inhibitors, arguably greatest and clearly statistically significant for the patients with reduced ejection fraction, but it seemed to happen with or without a history of heart failure. But if you look at cardiovascular death and all-cause mortality, all the benefit is in the patients with heart failure with reduced ejection fraction. If you look at ejection fraction, less than 30, less than 45, 30 to 45 and 45 to 55, there is a gradient here with regards to the benefit on cardiovascular death or hospitalized heart failure. Most of the benefit with regards to hospitalized heart failure is in the patients with eGFR less than 30. With regards to cardiovascular death, most of the benefit is in the patients less than 45, and similarly with all-cause death, with no evidence for benefit in those with lesser ejection fraction. And then lastly, with regards to the more primary endpoints of these trials, if you look at the MACE effect, you know, the thing that got the indications for some of the agents in this class for using these drugs, the MACE effect seems to be largely driven in the population with heart failure and reduced ejection fraction, which is a relatively small portion of the totality of the patients in the trial. And in the patients without known reduced ejection fraction, so they did have heart failure, they just couldn't find documentation of what kind of heart failure it was. And the patients with no history of heart failure, really very little evidence of benefit. With regards to renal endpoints, it doesn't seem to matter whether patients have heart failure or not. And then almost done with these meta-analyses. So with regards to the kidney disease outcomes in cardiovascular outcome trials, these benefits seem to be across the board in patients who have atherosclerotic cardiovascular disease and in patients who have multiple risk factors. If you look at broad renal endpoints that include albuminuria or macroalbuminuria, you see benefits for the GLP-1 receptor agonists and the SGLT2 inhibitors. But if you look at the narrow renal endpoints that throw out the somewhat less or more controversial or less impactful endpoints like macroalbuminuria, you see uncertain benefit for the GLP-1 receptor agonist, but again, very strong evidence for benefit, a hazard ratio of 0.55 for the class with regards to these narrow renal endpoints. The one thing that was left after the cardiovascular outcome trials is some uncertainty, a p-value for interaction about whether the benefits of SGLT2 inhibitors were really dependent on the estimated GFR, and you can see that a greater level of evidence in the patients with higher GFRs and a lesser level of evidence for patients with the lower GFRs, and therefore we have the Credence trial published last month in the New England Journal. So the thing that was different about this trial, it was a renal outcome trial. The patients that were included had broader A1C down to 6.5. They had to have an eGFR between 30 and 90. They had to have a urine albumin to creatinine ratio from 300 to 5,000, so clinical proteinuria. And they had to be on a stable and maximally tolerated dose of an ACE inhibitor or ARB for at least 4 weeks. So they had a 2-week run-in in which these were established. They were randomized to canagliflozin at the lower dose, 100 milligrams a day, or placebo. This was done in a double-blind fashion. And they continued the canagliflozin until patients went on dialysis or received a kidney transplant, even if their eGFR fell less than 30. And what you can see, the primary endpoint included cardiovascular death as well as renal endpoints, but was highly statistically significant. The study was stopped early at a pre-specified or pre-planned look for efficacy. And you can see that each of the components of the composite contributed to the outcome. So everything is on the left side here. When you look at cardiovascular events, also reduced. Hospitalization for heart failure, also reduced. And if you look at the pure renal endpoint, end-stage kidney disease, doubling of creatinine or renal death, again, highly statistically significant, a hazard ratio of 0.66. And then with regard to the question I raised earlier about whether these drugs worked in patients with more advanced kidney disease from an eGFR perspective, clearly it works in patients with an eGFR of 30 to 45 and 45 to 60, no evidence of heterogeneity. And the benefit for kidney disease reduction extends below 45, where none of the current agents are approved by the FDA for use. So the Credence trial, the blue box defines the inclusion criteria for the cardiovascular outcome trials, and here basically where these trials were with regards to baseline eGFR and urine albumin to creatinine ratio. The Credence trial goes to much more advanced kidney disease, averaging in this very high risk category here, but including all of these patients here. Now, this is about 5% of the diabetes population belong in this box, so this is not the common kidney disease that you see in your clinical practice, though you certainly do see these patients from time to time. So to summarize what's new regarding the SGLT2 inhibitors and GLP-1 receptor agonists for cardiovascular trials, from the cardiovascular trials, basically, I think the recommendations from the ADA EASD remain reasonable. The MACE benefits suggest that GLP-1 receptor agonists and SGLT2 inhibitors are similar in their effect to reduce MACE events. There's heterogeneity among the GLP-1 receptor agonists that suggests that maybe there's one or more of them that are a little bit better than all the rest. There is heterogeneity among the SGLT2 inhibitors with regards to mortality. That was only demonstrated with empagliflozin in the EMPA-REG trial. It's dragging the entire class to cardiovascular benefit, which has led some to question about whether there is a reduction in mortality with SGLT2 inhibitors. The SGLT2 inhibitors have clear benefits in reducing hospitalized heart failure, particularly in those with reduced ejection fraction, particularly in those with an EF less than 30. The mortality and MACE benefits of SGLT2 inhibitors seem to be largely in those with HFrEF, which raises the question about whether what is the true cardiovascular benefit in the patient with straight up atherosclerotic cardiovascular disease, had an MI and bypass surgery, never has had heart failure in their life. What is the role of SGLT2 inhibitors there? And I would admit that's a controversial question. And then with regards to chronic kidney disease, now the benefits around chronic kidney disease are incontrovertible for those patients with a urine albumin to creatinine ratio greater than 300, particularly with an eGFR less than 45. And that's an area that probably needs to be more amplified in the guidance from the American Diabetes Association. And one of the last slides that I want to show you is this one here. So, a lot of people, when they look at these trials, they say, well, this is not such a big deal. We really need to focus on lipid lowering and blood pressure management in patients with diabetes. And so I went to this website, the number needed to treat group, that updates constantly on numbers needed to treat for important clinical problems. And when you look in patients with diabetes and pre-existing cardiovascular disease, it takes 100 patients to prevent a death using statin therapy for 5 years. Now, you prevent a lot of MIs and strokes and do all kinds of great things. So this is just about death. For antihypertensive therapy, about 100 as well for 5 years. These GLP-1 receptor agonists and SGLT2 inhibitors, for mortality at least, in patients with pre-existing vascular disease, the number needed to treat compare very favorably, particularly when you think that these are 3-year studies as opposed to 5-year studies. So these are big deal effects for patients with type 2 diabetes. And then the thing to keep in mind is it's very complicated to understand what to do, because there's lots of people with type 2 diabetes. Many of them also have heart failure. Many of them also have coronary artery disease. Many of them also have chronic kidney disease. And when you start going into these higher order combinations, what you see is that many of the patients with one of these adverse consequences, like heart failure, have the other ones as well. So all of these analyses I've shown you are difficult because many of the patients are overlapping. I just wanted to quickly talk about what to do with patients who don't have atherosclerotic cardiovascular disease. So there's language about the drug selections to make if hypoglycemia is a big deal, a police officer, a firefighter, someone that does construction. There's language around weight loss. Again, the GLP-1 receptor agonists and the SGLT2 inhibitors are the effective agents in that area. And there's language around cost. And here, it's the sulfonylureas and thiazolidinediones that are recommended after metformin. The American College of Physicians recommends insulin here. We'll leave it at that. And then lastly, the last sort of big deal recommendation is the ADA recommends that if a patient needs the additional efficacy of an injected agent, they should start with a GLP-1 receptor agonist. If there's concern that the patient might actually have type 1 diabetes, insulin is clearly the first choice. But because of lower risk of hypoglycemia, weight loss instead of weight gain, and the cardiovascular benefits, that's recommended. And I'm going to skip the glycemic targets, unfortunately, and just say thank you. I guess I have 30 seconds for questions.
All right. Thank you. Yeah, so in the interest of time, I'm actually going to invite anyone who has questions to come down and talk with Dr. Buse, and let's give one more round of applause for a great talk.